The National Lung Screening Trial enrolled over 53,000 subjects looking for a way to reduce lung cancer mortality. In the patients who underwent screening CT scans, we were able to reduce the lung cancer death rate by 20%. This means that for every 300 patients screened, we were able to save one life. Lung cancer is the leading cause of cancer death in the United States and worldwide today. For other cancers, such as the breast, prostate gland, cervix, and colon, we have screening tests that have been shown to reduce cancer mortality. The results of this trial are particularly important because for the first time we are now able to show we can reduce lung cancer death rates with a screening test.
The only people who benefit from this type of screening are people between the ages of 55 and 74 years who've smoked a certain amount, and we currently measure cigarettes exposure by a term called pack years. So 1 pack per day for 30 years would be 30 pack years. Only people who smoke 30 or more pack years were eligible to be enrolled in the study, and we know then that only those people would benefit from this form of screening. Well, the results of this study are going to prompt a lot of people to ask the question, why don't we screen everybody? And the simple answer is that this study didn't enroll everybody. It enrolled a very narrow segment of the population, and it's only that segment that we know can benefit from this form of screening with CT scans done annually. In fact, we know that we could probably do more harm than good if we start screening people who aren't at high risk for lung cancer, because of the fact that we'll find many things that aren't cancer. It'll expose these people to other tests, some of which have risk.
One of the drawbacks of screening for lung cancer with CT is that many, if not most people undergoing the test will have abnormalities that are not lung cancer. Some of these are things like aneurysms, which are good to know about to prevent mortality from that disease process. But other abnormalities are not very specific, and we don't know what they mean for the patient. They would have to undergo additional diagnostic testing, some of which is quite invasive, to figure out the significance of these findings. This adds both cost as well as potential complications to their ongoing medical care delivery.
This is an extremely important finding. We've been waiting 40 years for the results of screening studies to show that we have a test that can truly reduce one's chance of dying from lung cancer. So now to have a tool that we know reduces one's chance of dying from lung cancer is an extremely exciting thing for those of us that deal with lung cancer patients on a regular basis.